As the leading professional association dedicated to infection preventionists, APIC provides the resources, thought leadership, education, and comprehensive training to help you protect those in your care. More than 15,000 IPs globally depend on APIC to help them develop and manage top-tier infection prevention and control programs. Join APIC today and unlock exclusive benefits such as educational content, access to cutting-edge research via our journal, and networking with peers to propel your career to new heights.
You are listening to the 5-Second Rule podcast presented by APIC, the Association for Professionals in Infection Control and Epidemiology. This podcast is produced by the APIC Communications Committee and is intended to be a conversation between our hosts and professionals practicing in the infection prevention and control industry. You will learn and be entertained, but most of all, we hope you will be inspired by our community and the work of our peers. And now, on to the show.
The following is a special episode of the 5-Second Rule podcast. We interviewed 3 oral abstract and poster presenters at the APIC 24 conference in San Antonio, Texas. You will hear from Andrea Lombard about reducing dental unit waterline biofilm growth, from Payal Patel and Tammy Hull about lessons they learned from a measles outbreak, and from Leslie Coleman regarding her veterinary occupational health and infection control assessment program. Now, on with the show. Today, we have Andrea Lombard, who has a poster here at APIC 24.
Hi, Andrea. It's so nice to have you. Thank you for joining us.
Welcome.
I'm happy to be here.
So tell us a little bit about your poster and your research.
So the poster title, which was harder almost to come up with than the actual work, is entitled Multi-Prong Interventions, Organizational Behavioral Changes, and Ongoing Monitoring Reduce Dental Unit Waterline Biofilm Growth. And it was important to put the dates down. This was a 2.5-year project.
Wow.
So we started in June of 2021, and we didn't reach our goal until November of 2023. And this really highlights the importance of collaboration, buy-in, education, the role that we play in investigative work and research and assessment, and making sure that we have the tools for our staff, and trust. Just when that trust was really built and our staff was empowered to really make the choices, that's when we had this paradigm shift where we got our momentum to succeed.
Andrea, that's so interesting. I know from personal experience, just going to the dental office as an IP, you definitely see major areas of opportunity in that space. But explain to us what precipitated this project. What about your institution necessitated the dental unit waterline policy?
Great question. So context. I start at an FQHC, which is a federally qualified health center. It's an ambulatory clinic. We had 5 service lines, one of which is dental. And I started my employment there during the pandemic. The dental office department was closed. So my instructions were focused on COVID. And we had a joint commission visit in June of 2021. Of course, sterilization was perfect, but dental water lines, this was new to me. And we're like, well, we have a municipal water source. We know what the cultures are and the results of the water. We have a water line filter system, an iodine filter that is at the hub of every operatory. We have 13 operatories. And then we had to start digging about dental water line maintenance. We have a lot of repairs to do. We reopened a water bottle system so we could shock the system. We could start culturing, and we could implement and monitor a new practice.
So for those of us that are not within the dental space, what exactly is an operatory?
An operatory is a fancy word to the room, the exam room.
Okay.
It's where you have your dental chair. It's where you have your hand washing sink. You have your cuspidor. You have the big light. You have all your air water lines, your suction. So when you go into your dentist's office, that room would be considered an operatory.
Thank you.
And as Lorenza was saying, I think a lot of infection preventionists don't have the experience in the dental operatory space. So what references, how did you tackle this with this new project and this new facility? Where did you go to reference those materials to help you?
That's an excellent question too. So the first thing is an assessment, right? I read everything I could possibly read. I called every vendor I could possibly get my hands on. Our dental director had a membership to American Dental Association, so I went through that. OSAP, which was called the Organization of Asepsis and Safety, is now called, as of May 31st, ADS, Association of Dental Safety, and they're rebranding themselves after decades of being OSAP. So they have a website. Of course, I went to APIC and CDC. CDC's guidelines 2003. Not a whole lot on dental water lines except what the minimum requirement is for quality of water. So it's a lot of digging. It's a lot of your IFUs. I had old chairs, like I said, so we went and we did a lot of repairs. We brought in our vendors and our preventative maintenance team. And it's really the investigative work that we do to put it together and to put an education program together and to include a seasoned staff that thought they were doing everything properly. And so there was a trust building piece to that too, once you got your education down. I had to learn what a narrow water line was. I traced lines. I got on my hands and knees and followed what was in that chair. I did the cultures. So it was fun to do that, but I had to humble myself and admit I knew nothing and build that trust and establish my credibility as I did what we were doing.
And Andrea, how long have you been in IP?
Longer than I want to admit.
How powerful was that statement that you had to humble yourself?
Yes.
Because we get into, I've been doing this for 5 years or 10 years or 20 years, but there's still more to learn in every aspect. So I love that.
I'm a lifelong learner. I am a humble person, so I have no problem saying I don't know. I have to go get that answer, and I'll bring it back.
Absolutely. So my question is twofold. So exactly who were the stakeholders that you partnered with? Was it the dental hygienist and the dentist? And in addition to that, who exactly did you report the outcome measures to so that they could sustain that level of success regarding this initiative?
Okay. Again, excellent questions. So we have dental assistants and we have now three dental hygienists. So those were my immediate stakeholders. During this time, we also have an infection control liaison program. So I had two dental hygienists that they were my champions. Other stakeholders were my vendors, the people that were supplying us. I would call for technical assistance, and I felt that they were just as important on my team because I was calling and getting educated. And I was calling people who were developing our products. Also during this time, I got a new boss. So she's the co-author on this, our CQO, our Chief Quality Officer. And what also helped during this time is we were doing a cultural, behavioral, intentional culture change. So that was giving more accountability and collaboration within our staff. So all these things were kind of happening together, but the perfect storm. What happens with behavioral changes and process? It's, you have that group process where there is some storming that's happening along the way. And it is uncomfortable, and you have to be patient with that. So one of the things that our CQO did was establish department projects. And this became one of the department projects for dental. So that helped. So all these pieces kind of came together.
So I did read in your poster how you experienced staff resistance. So you have named your key stakeholders and you beautifully laid out how you got them involved. But tell me a little bit about that resistance and how you overcame it.
So some of our staff is very seasoned. They've been doing this for decades. One of the things that happened was I had to step back. I had to let the staff choose the products that they wanted to choose. I had to, no ego. I had to really let my ego go and let the staff really empower the staff to make some choices. Our dental director identified that, and then she thought that it would be a really good idea for me to meet with the dental staff at least once a month. And it was tough at first. And we had some meetings that were not that comfortable. But when we got to our victory lane and we did our victory lap, we were able to take a step back and say we did this together.
Absolutely. And I know that that's a theme in many difficult and or challenging situations. Once you go through the rigor of, addressing the issue at hand, sometimes you can come out on a positive light. Andrea, thank you for sharing your knowledge with us.
I do want to say change agents sometimes are the person that may get the heat. And try not to take it personally. It is very hard to really step back and look at the bigger picture and just keep going and patiently just keep persevering.
I love that. Can I get a whoop? Yes. I'm hearing perseverance. I'm hearing let go of ego. I'm hearing humble. I'm hearing team building and collaboration. So congratulations on this project. And thank you very much for sharing it with us.
I'm thrilled to share it with you. I hope it helps other people. It's great to be here. Excellent. Thank you.
Switching gears, we will now talk to Payal Patel and Tammy Holt on their poster here at APIC 24.
Payal, Tammy, welcome to the show.
Thanks for having us. Yes, we're excited to be here.
Thank you. Payal, tell us about your poster project.
So our poster was really to talk about the lessons learned from our measles outbreak that occurred in 2022. We really wanted to give, we all know how outbreaks work and what to do, but we wanted to shift it to a lessons learned for anyone who might be experiencing an outbreak in the future. So we really wanted to highlight some of the proactive efforts that you should be taking as an infection preventionist.
I love that. So I know in your poster you mentioned that this was the 5th largest outbreak since measles eradication. So tell us, where was your outbreak? What region did it involve?
So it involved Columbus, Ohio, Nationwide Children's Hospital, mostly the local county, with a few outlying patients living in that line.
Okay. So Central Ohio. Okay. All right. Thank you for the context.
Yeah, and I know that one of the barriers or issues related to the outbreak was vaccine hesitancy. So explain to us, how did you address vaccine hesitancy in the population that was directly impacted? And also explain to us what population was impacted by this outbreak.
Yeah, so it was a vaccine hesitancy, in the Columbus, Ohio area. It turns out there a lot of this specific population that the outbreak was occurring in, they were under vaccinated and had been for some time. So during the outbreak, our local public health department ran a vaccine campaign, and they focused on having areas to offer the vaccine, the MMR vaccine at like schools. They hung up posters at local restaurants, really to create awareness, because we knew that vaccine hesitancy was already kind of there, but they really wanted to debunk those myths that were going around while the outbreak was occurring.
I love that. And so you mentioned that this was a retrospective study of all of the cases. So tell us a little bit about what you learned from the cases that were identified.
So we learned communication is very important, important lesson. It's easy to have a proactive toolkit and things of that nature. You feel like you're all set up, but then when you're really put in the scenario, you're like, oh my goodness, now what do we do? So lots of rapid cycle improvements. You put something in place, quickly improve upon it, and put in another algorithm or toolkit, more communication.
Do you feel like the exposures for this particular outbreak occurred in a community setting, or was it because these sick patients presented to the hospital and then was perhaps spread in a healthcare type situation because they went to seek care at their primary care doctor or in an emergency room?
I'd like to acknowledge that it was respiratory season. So we were seeing COVID, influenza, RSV around the same time. During the outbreak investigation, public health was able to identify that a lot of these exposures were occurring at school-based locations. So it was kind of a combination of both. We had measures in place for our EDs and urgent cares. So it was really hard to identify, was that patient coming in because they had a respiratory illness, or was it measles, because that onset of rash isn't going to be there. So a lot of the symptoms were similar. So I think it was a combination of both.
So Tammy, explain to us your partnership with the health department as it relates to your organization addressing this outbreak. And in addition to that, what areas of opportunity did you identify with that partnership?
Well, luckily, we have a very good relationship with our local health department. They were, they're open to give us a call, and we could communicate easily with them. So that was a huge benefit. And then opportunities, identified would be just the communication. Again, having a high number of cases, a high number of exposures. There's a lot of information going back and forth. So centralizing that information and quick or timely communication, it's a huge needed option.
Yes. Well, and you bring up a really good point about it also being in the middle of respiratory season for other things. And so if someone comes in with a fever and a cough, how do you know it's measles, or how do you know it's something else? Was there anything that you were able to say, okay, if they answer yes to this question, they're going to be in airborne isolation?
Yeah, there was. We implemented a heightened travel screening or enhanced travel screening. Obviously, if some parents had already known that their child was exposed, they'd go right up to registration, and registration staff would know what to do and communicate to the nursing staff taking care of them. If not, that enhanced screening looked for fevers plus cough if they've recently traveled, and if they were even given a dose of MMR. So if they responded yes to one of those things, a measles alert would pop up on our EMR system, and that would flag registration to do the same steps and immediately room them if we didn't have an airborne isolation room available.
So Tammy, from your purview, what opportunities could be instituted in the future to prevent such a large-scale measles outbreak? I know Pyle indicated that now you have enhanced travel screening. What additional areas of opportunity did you identify to prevent this outbreak?
I think it's good to have staff awareness. Again, we're a pediatric hospital. A lot of kids come in with sniffles, congestion, things of that nature. So just to have in the back of your mind, could be measles if the patient traveled, have the 3C symptoms. So it basically clinician awareness, whether that's the physician or registration staff. We would just want to get the patients out of the waiting room to reduce exposures.
Tell us about those 3 C's. What are they?
Cough, congestion, and
Conjunctivitis.
Yes,
Okay.
thank you.
3 C's.
Thank you. Now listeners have the 3 C's to help them with addressing a measles outbreak and/or cluster. Tammy Pyle, thank you for joining us on the show.
Thank you.
Very much.
Thank you. Last but not least, we have Leslie Coleman, presenter at APIC 24, to discuss her oral abstract.
Hi, Leslie.
Hi.
Thanks for joining us.
Thank you for having me.
So you have a much anticipated, talked about oral abstract coming up tomorrow. So tell us a little bit about the title and the work that you did.
Sure. So the abstract is on vocation program that I initiated at the Minnesota Department of Health. And this was started actually pre-pandemic before everything exploded, but it stands for the Veterinary Occupational Health and Infection Control Assessment Program. So I have been a veterinary infection preventionist for about 15 years. And over the course of the years, I've really seen the need for a program, not only within my state, but nationwide. So I've started to create tools and resources and guidance for veterinary clinics within the state of Minnesota. Once I started working at the Minnesota Department of Health, which was in 2016. So just the program was really there to provide training to veterinary staff, specifically veterinary technicians in the clinics, to become job trained veterinary infection preventionists, which I fondly call VIPs.
I saw that in your description.
That is cute. Leslie, one question that I do have is, how did you enter into the role of a veterinary IP?
That's a great question. So I'm a certified veterinary technician, and I was working at the University of Minnesota Veterinary Medical Center as a cardiology technician when I first started out. And it just happened that the role popped open, and the program had been initiated, but the person that was starting it had to drop out of the position. And so I jumped up at the opportunity to do it. I have a microbiology background.
Okay.
And so I was interested in, pathogens and how things work like that. And so in 2008, I started the veterinary infection preventionist role at the VMC, and worked there for 7.5 years. I was trained in actually by a human infection preventionist.
Distinction.
Mhm. And then in 2016, I went to work at the Minnesota.
Yeah. So exactly what evidence-based practice do you utilize as it's called a VIP, a veterinary IP. So what evidence-based practice do you use, even when you're providing recommendations to prospective stakeholders?
Another great question. There's not a lot of evidence-based practices. There's a lot of guidelines that have been developed over the years by great people that are working in the field. There's quite a few DVMs and other microbiologists that have been working as infection preventionists in the field for a long time. So there's a lot of documents that are kind of written by different people all over the place, but we really don't have that collaboration piece. We're missing that consensus piece of all being on the same page as far as even terminology. So there's different terminology used in different guidelines that are out there. And there is, just that we're lacking those pieces of those tools and guidelines for veterinary clinics in general.
Wow. So with the inception of the VOHICA, tell us a little bit about that project. It looks like you had 10 veterinary clinics that were involved in this project. Tell us a little bit about.
Yeah, so it started out with 10 veterinary clinics. I actually was pretty overwhelmed by the response that I got when I sent out the call for enrollment in the program. I had actually 30 facilities that responded. And for me, that was pretty overwhelming because I didn't think I was going to get anybody interested in infection control at all. So we narrowed it down to 10 and, chose those facilities based off of
if they had any SOPs or policies already in place, if they had somebody interested in being the VIP for the facility. Administration had to be completely on board with it because it was going to take time out of that person's job to do this role. And then we looked at also demographics as far as where they were located within the state, because we really wanted to capture at least 5 rural facilities to try to see what their needs were compared to more metro type facilities. We were also looking for an assortment of different types of facilities. So we had a zoo in there, we had shelters, we had companion animal, and we had large animal involved in it.
I didn't realize that it was okay.
Yeah, there are so many different kinds of animal care facilities that I really just wanted to get a taste for what was going on and who's doing what in these facilities. So that is how we got the program started. And then the pandemic hit, so we had gotten in site visits at all 10 facilities initially, and then when the pandemic hit, we were on pause.
Because you started in August of 2019.
So we started right before the pandemic, so the August of 2018, because the pandemic was 2020. Okay, never mind. So
I think it's all a blur.
Blur in my head. So August of 2019 is when we started. So we rapidly got in at least one site visit. We were planning to do, one, it's the initial 6 months, 12 months, but, everything exploded. And so, we kind of lost after the pandemic when we restarted about a year later. We lost 4 facilities because of the, people were burned out and they were understaffed in the clinics. Facilities just didn't have the time and the capabilities to put into it anymore because they were overloaded with animals because so many people had gotten animals, during the isolation period that they needed to bring them to clinics and they just couldn't handle the caseload.
So Leslie, share with us the results of your study.
And so a basic part of the program was a risk assessment tool that I created, because there's 0 specific veterinary risk assessment tools that were really, narrowed down all the components of infection control. There were a couple, general infection control risk assessments available out there, but they were just like, hey, do people wash their hands? I really wanted to look at the nitty gritty of like, where are the sinks located? Where are hand sanitizers located? Like all of that stuff to really be a complete risk assessment. So I created that for veterinary clinics. When I did the initial site visits, I did the risk assessment for them and then provided them back with a summary, a very nice color-coded summary, easy to follow, and then a post-assessment follow-up tool so that they could document their progress as they went along, so they could really see what they were doing after I did the risk assessment. The risk assessment also was created to provide a score. So it was a quantitative measurement as well, so that they could take it 1 year and then take it a year later and see their improvement. And I saw improvement from the first risk assessment and then the one we did after the pandemic hit. So we only got 2 in. Every facility improved in every single metric in the risk assessment. So that was really nice to see that it actually made a difference to train these people and that they implemented a lot of the recommendations that we provided.
I noticed in your summary that you used 17 infection control best practices, but you also incorporated 14 occupational health. So I love how it is encompassing the safety of the patients and people who take care of the patients. Were there any of those best practices that stood out as like, okay, no one's getting this one, like it was a major fallout?
Yeah, there were a couple actually. So for the 17 ones, and I did take those actually from, the ICAR assessments from the CDC. Yes. Kind of manipulated some of those and integrated some other ones that were important in our field. Cleaning and disinfection was a huge one. Just teaching people how to basically clean and disinfect and which disinfectants they're using. Many clinics were using disinfectants that weren't working, or they were using them at the wrong time period, or the wrong dilutions. And so I saw huge improvement just in cleaning and disinfection, which, can make a huge difference in transmission of pathogens in any facility. So that, and I did see an increase in PPE usage. So just making sure they have the right PPE, that they're trained on how to put the PPE on. So donning and doffing is non-existent. Any of that training is non-existent in veterinary facilities. So to do that training so they understand why they're wearing it, how to take it off, how to put it on, all of that stuff. I saw drastic improvement in those fields as well.
Thank you for that. So based on what you previously noted, that there is an area of opportunity in having guidance within your respective field, what is the future outlook, maybe with, widening this, your study and or widening better veterinary medicine, infection control related guidance?
Yeah. So at this point, I decided to try to kind of get all of the professionals all in one room after I saw that this program was successful, that it can have, these tools are needed and they can make a difference in these facilities. And so I kind of gathered a network of people already doing this within the field, this last January. And so we formed a networking team of professionals. And now we have actually gone to APIC, and they have agreed to support veterinary infection prevention, and we are forming a veterinary infection prevention council.
Congratulations!
Which will be launching in hopefully the next month or so. So I'm really excited. It's moving very fast, but to get everybody just together on the same platform is a huge start for our field. To just have a place for all the resources to be in one place where we can all go find them, because right now they're all over the place. To get the people that have been doing this for a long time together, to share what they're doing and their, what's worked, what hasn't worked. I'm just really excited to get all the people together in the same room. So
I'm excited for you. Leslie, I thank you for your time.
Yes, I'm very excited too. I think that you've really highlighted a need that needs to be addressed. And I'm excited to see this from, the ground zero, and then building this up, as we protect the population from zoonotic diseases, in the news with the avian influenza, jumping from species. It's very, very important that we do address the issues in veterinary health to protect our communities and keep our pets safe as well. So thank you.
You're welcome.
Thanks for listening to APIC's 5-Second Rule Show. We want to hear from you. Visit us at www.5secondruleshow.org. That's with the number 5, where you can contribute to the conversation. Make sure you subscribe and rate us wherever you listen to your podcasts. We're so appreciative of the hard work each of you do every day to make a safer world through infection prevention. Remember, IP stands for Important Person. You are awesome. Stay safe, and we'll see you next time.